Welcome to Access Amplified, the podcast where we shine a light on how digital health is increasing access to care and advancing equity around the world. I'm your host, Joanna Brownold, and our podcast is brought to you by TytoCare. In each episode, we sit down with healthcare leaders who are doing the work, not just reimagining access, but rebuilding it from the ground up. Today, I'm joined by Michael Levy, co-founder and CEO of the Digital Health Institute for Transformation, better known as DHIT. Michael, thank you so much for joining us today.
It's a pleasure. Thanks for having me, Joanna.
Michael is a driving force behind community-led digital health innovation, helping turn lived experiences into scalable solutions. In our conversation, he's going to share how DHIT's health innovation sprints are upending traditional models by starting with the people who are the most affected, not with the systems in charge. And we're going to dig into some real-life case studies, the difference between impact and intention, and what it takes to build a truly learning healthcare ecosystem. So let's get started. Michael, you've said that we need to flip the model, start with people, not systems. What does that actually look like in practice? And why is it such a critical shift if we want to improve access and equity?
Yeah, great question, Joanna. Thanks for having me again. And what a great question to start with. Flipping the system is a complex question to answer because depending on your point of view, it might look a little different. From a healthcare system perspective, we're looking at going from disease to health. When we're looking at software, we go from waterfall to agile, right? When we look at algorithms, we're looking from going from C-suite central decision trees to edge ad hoc processing. And so when we say we're flipping the system, we're seeing a transformation from the 20th century to the 21st century of the requirements needed to deliver value in not the systems and the C-suites and or the heads of many, but at a hyper-local, more idiosyncratic nature, i.e. in our community, in our homes, in ourselves. And we see this really shaping up in the healthcare equation anchored around social determinants of health and this burgeoning space that's bringing more vision and insight around, what does it mean to go and collect these social determinants of health and how do you care for these social determinants of health. And you're seeing early indicators that we're moving from historical top-down models to getting closer to the community and to the person and saying what's happening there. And that's a lived experience. That's the day in the life of an individual. And so when we say we're going bottom up, we got to start with the day in the life of an individual and understanding what is the world they live in. And so we can talk a lot about the process we go through, but that's what we mean by flipping the system, is not going from a balance sheet or strategy or a C-suite narrative to service our community. It's saying from a community perspective, what are our needs and how can the resources in the community service us?
So it's I love that because it's a very personalized approach, but then gives you the ability to scale for that community. And I know that you do work closely with those communities to uncover some of those lived experiences and some of those unmet needs. What are some of the most, and obviously this is going to differ because we're talking about loads of different communities and loads of different people, and you've just spoken about how personalized it needs to be. But what are some of the most common gaps or pain points that you hear? And how are you kind of ensuring that those voices then do drive that innovation process?
Sure. I think I think double down on at DHIT is, again, an individual in a community has, I would think, a portfolio of attributes that come under a number of categories, i.e. Behavioral attributes, environmental attributes, economic attributes, biological and genetic attributes, and then medical system attributes. And each of these big categories frame a lot of different levers that are at play, roughly about 80 to 90 different drivers that are at play in one person's life that don't really make it into the healthcare system, like, for instance, sleep quality, daycare coverage, access to green space, whether
Mhm.
you have stairs in your house and or you're mobily fit, all of these very idiosyncratic, kind of questions map to the needs of our people, whether they're a diabetic, whether they're suffer from cardiomyopathy. These are disease states that our system gets paid by, but it's not the real life of the individuals who are trying not to be defined by those and be defined by who they are. And so
Right.
when you think about access, you have to map it to who they are, not to their
Right.
disease.
Right. That's what I was going to say is like you can separate those things as much as you want. And sometimes that is what our health systems want us to do. But obviously, when you're looking at the individual, whether they have a cat is going to impact if somebody is living with them with asthma, or whether they have to climb 3 flights of stairs is going to impact them if they have a cardiac disease. So I love this whole, I would call it almost like a whole person approach, but how do we feed that back into those organizations? How do the organizations go from those insights into actions without kind of falling back into the top down habits or the one size fits all
Yeah.
solution?
This is really, I would say, the multi-trillion-dollar question, right? Because
So
right
tell us the
now,
answer and
yeah.
we
Well,
can all
I,
make it
I
rich.
have a, I have a thesis, but unfortunately, it's not popular because it's not a light switch. It's not easy. It's hard because what digital transformation requires is culture and human transformation first. It's the
Okay.
understanding that we have to learn differently. We have to grow intentionally, and we have to collaborate to scale. And that is a human and analog process that when you build a digital enablement cycle into that, you are hitting inflection points of multiples throughout your journey, hence going
Uh-huh.
from version 1 to version 2 to version 3. But as a system, we have to be okay with going from version 1 to version 37, right? As a mentality, we've got to say, well, we're not really going to see the value of our work until the versions
Until
out there. And
right.
so from an organization perspective, we see a lot of organizations have great hope and investment in digital transformation, but it failed massively because they don't understand the cultural and the human needs to meet the transformation with intention and set by purpose, which is the currency of longevity and sustainability.
I think it's funny because we're lucky to have had some fantastic people speaking on this podcast so far. And I think some of those that I'm seeing as the ones who have managed to scale the biggest changes within their health systems are the ones who are approaching their projects exactly in that way. So, the way that I kind of defined it to them was like almost like a startup mentality where we're not going to, expect to build a solution that fits everyone and leave it at that. We're going to build a solution and then we're going to change the solution and then we're going to change the solution again. And that's not always popular in our
So let
system.
me double click on that for a second, because the operating system that I've shared with you, we
Mhm.
call it the 4Ds. It goes
Yeah.
discover, define, design, deliver. At a kind of a tool-based framework perspective, when we talk about next generation operating models and or tools and emerging capabilities that we see now in our employees and our staff, what we want out of the soft skills, it comes from the tying together of four key disciplines. This is our vantage point, and this is how we actually drive the 4D process. The
Yeah.
first D, discovery, is anchored in the principle of open innovation. It's to say stay open, don't have judgment, don't have bias of capabilities in what your system is yesterday. Be open to what's coming on and coming new and is potentially totally transformative or incremental, but be open. Then the next is human-centered design. Take a personal, patient-centered, consumer-centered, user-centered approach to what
Uh-huh.
matters most to the individuals that you are trying to serve and build value for. Okay, and then apply, lean to validate the riskiest assumptions and the simplest iterations and prototypes of, and then agile to scale it up from there based off of standard software principles and or technology principles. And when you do that, you end up bringing the ecosystem who gives blank has purpose together. You're able to rapid cycle validation and testing hypotheses, smooth back end implementation cycles, and build capacity at the same time.
So I guess the one challenge, but difficulty with this approach, especially in terms of starting hyperlocal, is that scale is where things tend to become economical. Why do you think that, or where do you think these challenges lie for these health systems?
Let's take the first question and apply it here and flip the perspective.
Yeah.
You said scale is economical. I say that equals commercial mindset. Okay.
Yes.
However, health outcomes equals economical, and that is
Okay.
societal impact. And
Okay.
if anchored to health outcomes, we're now solving problems that are building capacity and upward mobility in our society, which is
Uh-huh.
going to give greater productivity and usefulness in our economic capacity as it relates to GDP. And so we've got to stop thinking again top down. And let me layer this down for a second. Top down goes like this. If I'm a supply chain, I'm up here, right? I'm floating all my service providers, my digital health companies, my payers, my pharma, even the healthcare system is right here, right? Okay, so that's commercial. Okay, but when you go down to the ground here, this
Yeah.
is where people are. This is where people are, right? When you go here, you got to go through the commercial layer first. Then you go to the quality improvement layer, which is clinical care.
Okay.
Can our commercial solution get implemented into the system and show quality outcomes? Then you go to research and you say, can I go get validated studies that my improvement project is
It's actually improving.
valid? And then I go down to the market and drive awareness through education. That is flawed model. Okay. The appropriate model, which takes a little bit longer and a much more intention, is to go education, bottom up, let's co-learn, let's discover together, let's define through research, let's validate together, let's implement and gain confidence through quality improvement of an N of one, and then let's bring commercial if applicable to many. Very different model.
You're right. It's the opposite. And I feel like I've just been told off by a teacher who's so much smarter than me.
Just a practitioner that's been doing it so much longer, let's say.
So what do you think is the difference then? Not every health system is going to flip everything on their head tomorrow. But in your experience, what's the difference between those organizations that talk about transformation, that kind of talk the talk, and those that actually walk the walk and actually make things happen? Because that is a very different ball game.
Yeah, I think the way I would kind of suppose frame it is the macro transition from the healthcare system acting in a reactive manner to the healthcare system acting in a proactive manner,
Uh-huh.
which is referred to as an experience driven mindset, an experience driven industry. And so the healthcare system, where we've seen the greatest strides of healthcare enterprises getting out of their way, is by letting the consumer user engagement, attention driven economy lead them
Okay.
versus the stop what you're doing, come to us, we're the best. Very different model when you're talking about disease versus health, because health is about a longitudinal journey that's super personal and super local to the realities of Michael Levy. And if you're trying to engage with me as an experience center, right, you're going to have to understand like what gets me up in the morning and how do I engage throughout the day and where do I go and what apps I use, and that's these are all questions that retail brands usually ask, not healthcare systems. And so what is a retail brand? What is Disney? They're experience centers. And so when a healthcare system starts operating as an experience center, they're trying to drive a discrete data capture at the edge in their communities as robustly as possible, and having operating models that respond to that inbound knowledge and insights at the edge before it even gets to some C-suite, because someone in a ivory tower doesn't know what the community needs, right?
And how do we, I mean, yes, I agree with everything you said. It makes a lot of sense. How do we make that switch? Because so many health systems, I would even wager that almost all health systems are struggling with budgets, with the economy, with a lack of clinicians. And your solution solves these problems, but it solves these problems later. And so many of them need solutions now. So how do we get them? I mean, is this like a digital tool thing? Is this a mindset change? How do we get them
Well,
there?
yeah, our kind of model to support organizations, in this manner generally recommend and suggest a duality approach to transitioning and meeting the new needs of the community in the digital century, which is, you have to understand that the operating model that you operate within right now will not succeed in its current environment. So you either figure out an ecosystem partner strategy that builds that ecosystem outside, that essentially marginalizes you over time, thus creates a market around you. And then you are building the competitive advantage in that market pace based off the partnership strategy. And the best example that I can give you is like Tesla, right? I'm
It's
just
not.
talking about the technical model and the business
Mhm.
model innovation that Tesla delivered on, which is that their competitive advantage comes in the fact that they have more than 400 softwares that tie together, that are contracted and essentially managed from a contractor perspective to interoperate, such that the innovation is the integration between the 350 vendors plus that actually deliver the platform that drives the Tesla, right? And so it's not in a thematic manner, it's not the organization that has a brick and mortar that is able to be the anchor to what we think of. It's the virtual business that is stood up through the partner ecosystem, and how you build that ecosystem to solve discrete hyperlocal needs in that community. And it's agile enough to where, depending on the community, different parts of those ecosystems are firing at different times to solve. So you're building an agile framework that leverages your core incumbent, historical stature to be able to bring credibility, bring operating, kind of structure to it. But it has to live in an agile world that's firing to the needs of your core user base or stakeholder base in a somewhat agentic manner, right? Which is like
Uh-huh.
to say that it's auto firing. And that's what the great digital companies do. And even we're seeing from like pharma right now, increasingly building these digital ecosystems with that strategy in mind. We can no longer be a drug development company. We have to go to patient experience and excellence as well. Well, how do we do that? We can't build that inside of J&J or Pfizer. We got to go launch these big digital platforms where they're struggling is in the discrete community knowledge. So they have the innovation ecosystem, they have the partners in digital tools, but they don't have the ground force to match that capability set with the foundational knowledge that is necessary in the lived experiences and the needs.
Okay, so then my next question to you is, how do they get that? Do they go out onto the streets? Do they partner with grassroots organizations? If they're partnering with grassroots organizations, does that mean they don't necessarily own their own innovation? So then how do they get return on that innovation? Like, what does that look like then
Yeah,
practically?
I wish I had all the answers to that question.
That's why you're here. I thought you had all the
Well,
answers.
I have a simple, directionality, which is to say that the amount of value to unlock from an engaged group of individuals that want to improve their health is far superior than selling anything transactional today. Okay. And
Okay.
that is the bet that the world is making today on precision medicine, on personalized medicine, on consumer health, value-based care. I don't have the economic model similar to where Henry Ford brought out the car and didn't have the highway system, right? We're in the beginning years of what the 21st century is going to look like. And I'd posit that it's 1925 in the 21st century, where these individuals like myself, yourself, who are exploring and painfully working through discrete challenges to pave the new frontier, are in the early innings. And my call to action to those is to say, help us define it and build the economic models. This is what we're doing right now at DHIT.
Yeah.
What we can talk about this if there's time, but what we believe is the critical anchor laws of health that need to be defined to help us prove out the economics that caring for the future iterations of ourselves actually is more important than taking a drug today to optimize, the disease or other in broad standards, not all. I mean, I'm speaking generally right now, but the truth of the matter, John, is that you know nothing is in our favor at the moment. The same way that when Henry Ford brought out the car, 95% of the world was driving horse and buggies.
Yeah. But in if we start laying the groundwork now, right? If Henry Ford hadn't come out with the car, yeah, no, that makes a lot of sense. And I guess that kind of also brings us back around to, you had kind of mentioned starting with those individuals, starting with the members within the community. If you had to give, well, it's not if you had to give, you have to give, because I'm asking you to. One first step that healthcare leaders could use today to bring them closer to a more inclusive, equity first approach to digital care, what would you be?
Build discipline and institutional muscles around human-centered questioning, empathetic listening, and co-development cycles to enable power and voice to be heard from every community that you serve, and to ambitiously and urgently deliver resources to unlock the lives of those that you're supposed to be caring for, and not wait until they come to you in the hospital.
I kind of couldn't agree more. If you were gonna, we're telling people to go out into the community, find out what they know, look ahead, look and see and think what they might need in 10 years' time and start building towards that now. Let me ask you a bit more of a personal question to kind of wrap us up. You founded DHIT in 2017. A lot has changed in the healthcare landscape since then. But what keeps you inspired and what are you most proud of in the work that you're doing today?
Well, actually, inspiration, unfortunately, is not my driving force. It's urgency and pain. Pain because I feel like we could do so much more with the resources that we have. Urgency because my community and the people I care for, within my house, within my neighborhoods and the broader are struggling, I think, making sense of why the inefficiencies and the inadequacies occur. But I think inspiration comes perhaps from my daughters and seeing their eyes every morning, looking at their dad and saying, what are you doing? I know you're doing what you can do. Let's do it together and trying to help. That's inspiration. I think what I'm most proud of and what I'm most excited about right now is, DHIT is going to release. Actually, this will be the first time I mention it in on air or in public. We're going to release the periodic table of health elements shortly, which will be an interactive web-based educational center that helps support the education of the drivers of an individual's health, like Joanna, Michael Levy, like whoever you are. You have so many controls that are in your hands, not the system's hands. So part of our thesis is that taking back control is to take responsibility for what's in our control and to learn about it and to make our own conscious decisions and be intentional about how we might want to architect our future. And so I'm very excited as a scientist in background. I grew up with the periodic table of elements on my wall. I learned how the world was made from a chemistry perspective, right? Or an elements, but now, like, I think it's relevant we apply that same type of rigor and focus on how our health is made and how we can build better health systems for us as a person before we start solving more broadly, because each of us have quite a bit of control when you think about bottom up, and then we'll tell the system what we need from them.
I love that. I think both in terms of the inspiration that you mentioned and what you're proud of. These are really special things. So please keep working, keep pushing forward. Thank you so much for joining me. This has been a really great conversation.
It was such a pleasure, Joanna. Thank you so much.
Thank you. Just to wrap up quickly, if you have enjoyed today's conversations, please be sure to follow or subscribe wherever you get your podcasts. New episodes drop every 2 weeks. Please share this episode with a colleague who's passionate about digital health, access, or rethinking care delivery. Access Amplified is brought to you by Taito Care. I'm Joanna Brownold. Thanks so much for listening, and we'll see you next time.